An electrical impulse from the SA node has to travel through the atria to the AV node and down the His-Purkinje system to reach the ventricles and create a ventricular contraction. This process is reflected on ECG as the PR interval, which leads to a QRS complex. A delay in conduction in this system results in an atrioventricular conduction block or AV block, or simply heart block. Now, we have seen in the previous video that first degree AV block is simply prolongation of PR interval, the normal PR interval being 3 to 5 small squares. If the PR interval is longer than 5 small squares, we call it first degree heart block. And what is important to know is that in first degree heart block, although there is prolongation of PR interval, the P wave is always followed by a QRS complex. Here in the second degree AV block, there is prolongation of PR interval, and in some complexes there is a drop bit, meaning a QRS complex is absent. So first degree heart block is prolonged PR interval, and second degree heart block is prolonged PR interval plus drop bit. Now, the second degree AV block is of two types: Mobitz Type One, also known as Wenckebach phenomenon, and Mobitz Type Two. Now, in Mobitz Type One, aka Wenckebach phenomenon, there is progressive prolongation of PR interval until a QRS complex is dropped, meaning the PR interval just before the drop bit is the longest, while the PR interval just after the drop bit is the shortest. There is progressive prolongation of PR interval. Say the first PR interval is of 6 small squares, and the second PR interval 6.5 small squares, the third PR interval maybe 7 small squares, and then there will be a drop bit, then again starting with 6 small squares, 6.5, and so on. In Mobitz Type 2, there is intermittent drop bit just like Mobitz Type 1, but there is no progressive prolongation of PR interval. So the simplest way to remember first degree AV block, second degree AV block type 1, second degree AV block type 2 would be: first degree AV block is prolonged PR interval, second degree AV block type 1 a drop bit with a warning, and second degree AV block type 2 is a drop bit without a warning. The warning being progressive prolongation of PR interval. Let us try again. First degree AV block is simply prolonged PR interval. Second degree AV block Mobitz Type 1 or Wenckebach phenomenon, progressive prolongation of PR interval followed by a drop bit. Second degree AV block Mobitz Type 2, intermittent drop bit without progressive prolongation of PR interval. Now, Mobitz Type 1 or Wenckebach phenomenon is often a normal variant seen in individuals with a high vagal tone without evidence of structural heart disease. However, this rhythm can result from inferior myocardial ischemia, medication toxicity, hyperkalemia, cardiomyopathy, or following cardiac surgery. Common drugs that are known to cause AV block include beta blockers, digoxin, calcium channel blockers, and many antiarrhythmic agents. Recently, the immunosuppressant agent fingolimod used to treat relapsing multiple sclerosis was also found to cause AV block. Mobitz Type 2 is rarely seen in patients without structural heart disease. It is often associated with myocardial ischemia and fibrosis or cirrhosis of the myocardium. This rhythm often progresses to third degree AV block that is complete heart block. Other causes of AV block include infiltrative heart disease like amyloidosis, hemochromatosis, acute rheumatic fever, malignancies like lymphoma, hyperthyroidism, myxedema, collagen vascular diseases, cardiac tumors, or following transcatheter placement of valves, ethanol injection for hypertrophic cardiomyopathy, etc. In some patients, the AV conduction block may have a genetic trait. Several mutations in the SCN5A gene have been linked to familial AV conduction block. Mobitz Type 1 occurs because each depolarization results in the prolongation of the refractory period of the AV node. When an atrial impulse comes through the AV node during the relative refractory period, the impulse will be conducted more slowly, resulting in a prolongation of the PR interval. Eventually, an impulse comes when the AV node is in its absolute refractory period and will not be conducted. This will manifest on the ECG as a P wave that is not followed by a QRS complex, what is known as a drop bit. This non-conducted impulse allows time for the AV node to reset and the cycle continues. Mobitz Type 2 is often a problem in the infranodal conduction system, that is the His-Purkinje system, and therefore is associated with a widened QRS complex or a bundle branch block or a fascicular block. Patients with Mobitz Type 2 often present with fatigue, dyspnea, chest pain, pre-syncope or syncope, and even sudden cardiac arrest. Physical examination will often reveal bradycardia. Patients who have severe bradycardia resulting in hypotension and decreased cardiac output may be diaphoretic and pale. Patients who have a second-degree AV block secondary to myocardial ischemia may present with chest pain. Treatment for a Mobitz Type 1 is often not necessary. Occasionally, Type 1 blocks may result in bradycardia leading to hypotension. If hypotension and bradycardia occur, Type 1 blocks respond well to atropine. If unresponsive to atropine, pacing, either transcutaneous or transvenous, should be initiated for stabilization. If the patient is on any beta blockers, calcium channel blockers, or digoxin, the dose of this medication should be reduced or the medication discontinued. All patients with Mobitz 1 should be admitted and monitored. Treatment for a Mobitz Type 2 involves initiating pacing as soon as this rhythm is identified. Type 2 blocks imply structural damage to the AV conduction system. This rhythm often deteriorates into complete heart block. These patients require transvenous pacing until a permanent pacemaker is placed. Unlike Mobitz Type 1, patients that are bradycardia and hypotensive with a Mobitz Type 2 rhythm often do not respond to atropine.